Okay, so the knee and lower
today's
leg.
lecture is on the hip and
bones
the
of the
leg.
lower
When
leg
I talk about
include
the
tibia
tibia
and the
your
fibula.
thigh.
Tibia
What I
articulates
want
with
you
the
to get at
condyles
is
of the femur
this is
superiorly
describe the bones
and
that make
talus
the pelvis and the
inferiorly
hip.
to transmit weight
Describe
of
the
the
muscles
body
of the
to
pelvis
the
and the hip.
The fibula is
the
actually not a
lumbosacral
weight-bearing
plexus.
bone, but it's an important site of
So the
muscular
bones of the hip and the
attachments
leg that we're talking about is your hip
You
bone
can
is
have your
actually
fibula removed
also your pelvis,
and still
but your
have
hip bone is actually
pretty normal
formed
function.
by the ilium, ischium,
Shaft
and
of the tibia and
pubis
fibula are attached
that
by
are
a
generally
very strong
fused together to
interosseous
form your
membrane.
pelvis.
It's really,
At birth,
really
these
strong
three bones are
and
joined
thick.
by hyaline cartilage, but begin to fuse
So here's
around
the
15 to
interosseous
17
membrane.
years old, and
Okay.
completely fused
Tibia,
by 20 to 25.
much larger and thicker than your fibula.
So although the rigidly
fibula,
fused
though, does
adducted,
extend more
their names are
distally
still used to describe
than
the three
the tibia.
parts of the hip bone.
And as you can see, there's a lot of
Okay, so you
ligamentous
have your
support
ilium, which is this
in
large
here
part up
between
here.
your
So if
tibia and fibula.
when you
It is pretty much
stand and
ligamentous
put your
in this
hands
large
kind of
interosseous
on
membrane
what
that
think of as
holds
their
your
waist,
tibia
you're
and
actually on the
fibula together.
ilium. And then posterior,
Tibia is the second largest bone in the body, femur being the largest.
And then
it flares out at
pubic bone
both
in
ends to
front.
provide an increased
Okay, so
area
these
for articulation
three
and weight
bones
transfer.
fused together by
Proximal and widens
adulthood
to
are
form the
considered
lateral
the
and
hip
medial tibial
bone
condyles.
itself or your pelvis.
These tibial condyles overhang the shaft
Ilium
of the tibia
is the superior
medially
and largest
laterally
part of
and
your hip
posteriorly,
bone.
forming a
The
tibial
body
plateau
joins with the bodies
where
of the ischium
superior
and pubis to form
articulating
the
surfaces.
acetabulum.
Those
And that is the
superior
socket
articulating
where
surfaces
the
are going to
femoral head
articulate with the femoral condyles
and
to
that
form
actually
part
forms
of
your
knee
hip
joint.
joint. So the ala or wing is a thin
Okay,
wing-like
so those
posterior
surfaces that
lateral
articulate
portion
with
of
the
ilium
knee
that
joint
serves
are
as an
called the
attachment
articular
site for
surfaces.
muscle.
They are on the
Anterior
condyle.
and posterior, there are
of
two
the tibia.
projections called the
The
anterior,
intercondylar
posterior,
eminence
superior,
separates the two
and
articulating
posterior,
surfaces from each
inferior
other.
iliac
So it separates
spine.
medial from
These
lateral
two are
condyles. The eminence is actually two tubercles, medial and lateral.
Okay, so here is your ilium.
Right,
This
tuberals
whole
fit
thing
the
is that this is
intercondylar
all the
fossa
body
between
of
the
the
femoral
ilium.
condyles.
Here is your acetabulum. If you notice that your acetabulum is
knee
actually
ligaments which
formed
hold the femur
almost
and
in
tibia
thirds
together.
by
So
your
the
ilium,
the intercondylar
ischium,
eminence
and your pubis, a little less than a third.
really serves as an
pubis.
attachment for mostly ligamentous.
Okay, but back to
support.
ilium. We have this large iliac crest, and again, that's the top of
The anterolateral
tibial
tubercle, also known
ala
as
or wing, is
Gerdy's
this
tubercle.
big
From
bony.
the anterolateral aspect
sort of
of the
like
lateral
a fossa,
tibial
and this is
condyle,
really where
it's the
your
insertion site for the
gluteus medius
iliotibial
is going
tract,
to sit.
that big
You
fascial
have your
band
anterior
that I showed you in the previous
superior
lecture.
iliac spine, ASIS.
The lateral condyle also has
in
a
your
fibular
anterior
articular
inferior
facet,
iliac spine.
and that is where
Okay, you
the
also have those on the
fibula
back,
actually articulates
your
with the
posterior
tibia.
superior
It is
iliac spine
considered a joint.
and your
It's the
posterior
proximal tibial
inferior
fibular
iliac
joint.
spine. Your
The
anterior
posterior surface of the proximal part of the
um,
tibia, there's a ridge called the
superior and
inferior
inferior
line,
spines
and that's
are
the
used a
attachment
lot
for
more
the
as a
soleus.
guide for palpation because your ASIS
Shaft of the tibia
particularly
has
is very
anterior,
palpable.
medial, and interosseous
AS,
borders.
The A
On the
I,
anterior borders,
IS,
the tibial
the anterior
tuberosity,
inferior
and that
iliac
is
spine.
where
It's a little
the
less
patellar
palpable,
ligament
but
is
on
going
the
to
thinner person you
insert.
can find it.
Your
Your posterior,
there's an expansion on the
superior and
inferior part called the
inferior
medial
iliac
malleolus.
are really
right?
tough to
That's a
palpate
big bump
because
that
your
we would
glutes are
consider
sitting
part
on
of our
top
ankle
them,
joint.
so it's tough to get through the glutes.
And then distal end,
palpate
there's
them.
also a fibular notch for the
Okay, and this is just the other side
tibial-fibular joint.
of the
This under the tibia is inferior.
So here is
surface,
the only big
and
difference
that
here
is
which
for
is
articulation
the
with
auricle,
the talus,
the
of your
auricular
foot.
surface, and this is where you're
Okay,
going to
so here we
articulate
have an
with the
anterior
sacrum
view.
to form
So
the
here's what we care about.
sacroiliac
Here's your
joint.
tibial tuberosity.
Okay.
This is where your
So again,
patellar
this is the
ligament is
front
going
because
to
here's your
attach
AES,
and very
IS,
palpable.
and
So if you want to
A-
palpate the patellar ligament,
IS,
you find
and here
tibial
your posterior
tuberosity and
iliac
move proximally,
superior
and you'll be
inferior
right on
iliac
the
spines.
patellar tendon.
Okay, your iliac crest is a broad, thick,
have your
and
lateral
superior
condyle
bord of the ilium that
and your
runs from the
medial
ASIS
condyle.
to the PSIS.
Okay, you see
You
this
have the greater
flaring
sciatic notch is
that
cut out
happens both
inferior
medial
to
and
the
lateral, and that's what they
posterior
mean by the
inferior
condyles
iliac
overhang
spine.
the tibial shaft.
On the lateral surface of the wing, there are three
Here is
rough
your
curved
intercondylar
lines,
eminence.
anterior,
Going to be
posterior,
attachment
and
sites for
inferior
primarily your
gluteal lines
PCL
that
and
mark the
ACL.
origins of gluteal muscles. These are not
And
palpable,
here you have your
because, again, the
proximal
glutes are
tibial
sitting on
fibular
them, but
joint,
if we
and down here
remove
is
the
your
glutes
distal
from one of the
tibial
ilium, you may be
fibular
able to see
joint.
them. Okay, but again, look, it's just these
Also
lines.
distally,
So here is
you have the
your
articular
gluteal
surface
lines,
of your tibia, which is
anterior,
going to articulate with the talus of
inferior,
the ankle joint.
and posterior.
Posterior view, nothing
Again,
too exciting.
really just attachments
Posteriorly,
for
a lot of the same stuff.
glutes,
Soleal line, yeah, it's there, but
when we look at the
so
glutes,
what?
you'll
Again,
see that there's this
broad
broad fascial
attachment is
sort of
muscular. To
attachment,
say they
not
attach
just to
solely
those
on this
lines.
line is not accurate.
ischium. Forms the posterior
Fibula.
inferior part
It doesn't
of the
lie
hip bone.
exactly parallel to your
Superior
tibia.
part
It's
of the
actually
body,
somewhat posterior and
of
lateral
the
to your
ischium
tibia.
fuses with the pubis
Proximal
and ilium
fibula
to
has
form
an
the
apex, a
posterior
head, and a neck.
inferior aspect
Has
of the
anterior,
acetabulum.
posterior, and interosseous borders.
Inferior
Again,
part
same
is
thing as on the
referred to
tibia.
as the ramus and joins with the
Distal
ramus and
end
the pubic
enlarges
bone
laterally
to form
and
the
inferiorly to
boundaries
form
of
the lateral
the obturator
malleus.
foramen.
So this is the lateral side of your ankle.
Ischial spine is inferior to the greater sciatic notch and serves as a site for ligament attachment.
Like I said before, the lateral malleus
so here's your
extends
ischial
slightly more
spine.
distal than the medial,
Again,
and therefore
not really
is slightly
palpable.
more prone to injury.
You have a
and
lesser
fracture.
sciatic notch. This is primarily your
Okay,
body.
so same
your
picture
ischial.
showing you all the same
Okay,
stuff.
here is
Just
your
notice
ischial
how much
tuberosity.
more distally
this
the
is
lateral
very, very
malleus
palpable,
is than the
and it's
medial.
where we tend to sit when we sit properly. We should be sitting
Okay,
on
the joints of our knee.
Ischial tuberosity.
There are actually
as
three
we call them.
articulations here. One joint,
Very
three
palpable
articulations.
site for
Lateral
your
medial
hamstring
articulations
attachments.
between the femoral and tibial condyles.
And then you have your ramus of your
and the
ischium,
articulation
and you'll see
patella
that this
and the
ramus of the
femoral
ischium
condyle, which
joins
is called
with the
ramus
patellofemoral
of the
pubis and create this obturator
Okay, so there's
foramen,
the actual knee joint,
of
which
course
is
the
the
articular nerve
articulation
is
between
going to pass
tibia and
through.
fibula. And then there is the
And then here you'll see its part, its
patellofemoral joint as
contribution
well.
to the formation of the acetabulum. Pubis bones forms the anterior medial part of the hip bone, contributes to the anterior part of the acetabulum. Flattened body and two rami, superior and inferior ramus.
Your
The
knee joint
symphysial
itself, the
crest,
tibial femoral
crest
joint, is
or
considered
surface
a
is the area
synovial
that
joint, and
articulates
it's a
the
hinge
hinge
joint,
symphysis.
meaning it only
Pubic
really allows
tubercle serves
flexion
an
and
attachment for the
extension.
inguinal ligament. The pectineal line serves as an attachment for the
There
pectineus.
is minimal rotation that is allowed.
So
when the knee
pubis
is
is much
flexed.
less exciting.
Most
Sorry,
people
Here's
cannot
your superior
actively
pubic
rotate
ramus.
their tibia.
Inferior ramus is going to be
Although
down
very few
here.
people can.
Those are the
but
two
usually it's
main
more of a
things. And the other
passive
thing you
motion,
want to
and
know
it
is
happens
the
because of the
symphysial
structure of
surface.
the joint
The
itself.
pubic joint
When the knee is fully
itself
extended
is a
with the leg and
symphysis.
foot
It's
on the
a
ground
sliding
in a
joint
weight-bearing
just
situation, the
in
knee
between
locks because of a slight
right and
medial rotation of
Um,
the femur
symphysial
on the tibia,
surfaces
or
form the
lateral
pubic
rotation of the
surfaces.
tibia on the femur. Same thing. Popliteus muscle is responsible
Okay,
for
the
unlocking
obturator
the knee
foramen,
and allowing flexion
pointed
to
out in
occur
the
by
picture,
causing a slight
bounded by
lateral
rotation
rotation
of
of
the
the femur
ischium
on the
and the
tibia
rami.
to unlock the
It is
knee
a small
joint.
passageway for the obturator nerve and vessels. Obturator
Knee joint is
foramen
relatively
closed by
weak
a thin
mechanically
strong
because of the
membrane
incongruence
called
of its
the
articular
obturator
surface.
membrane, which is spelled
So
wrong.
I'm sure.
The
I'm
foramen
sure you've all
helps
heard
to
of
minimize
tons of
bony
ACL
bulk in the
injuries,
area, while the
MCL,
membrane
meniscus
maintains
tears.
the
I'm sure
surface
many of you
area
have had them.
needed for
That's because it is
muscle
not a
tension.
very structurally strong joint. The stability of the knee is really provided.
Okay, so
from,
here you go. Here's your
ligaments
obturator foramen.
and muscle.
You've got your obturator artery in
So
there.
of these
your
two,
obturator nerve is in
muscular
there,
strength is
and then you
most
have this
important because
obturator
it's something
membrane,
we can
which is
do
fiber
something
structure
about,
that,
and it can often
that
compensate
sort
for
of fills the
torn
hole.
or injured ligaments. So knee stability can often be restored.
The
by strengthening of
acetabulum,
surrounding
very
musculature,
important. This
even
is the
once ligaments
socket
are torn
for
or
the hip
stretched,
joint,
which is very, very
femoral
common.
head, and that femoral head inside
Joint also
this
has a very
acetabulum
strong
forms your
capsule.
actual hip joint. It's a large cup-shaped cavity and lateral aspect of the hip bone. Very important stuff.
That covers the
So
entire
let me go back
surface
to
of the
the
joint
acetabulum a
except
bit.
for the anterior
Um,
surface.
We're going to
Patella
talk
patella
in
ligament serves as a
kinesiology
joint
about the
capsule
acetabulum and its
anteriorly.
position and its orientation.
Joint capsule strengthened by
But it
5
plays a
extra
large
capsular
role
ligaments.
in
Extra
how
capsular
your
means they're
hips end up being
outside of the
positioned in
capsule.
adulthood, how
You
it
have your
orients
patellar
itself
ligament,
into space,
your fibular,
and what
collateral ligament,
how your
sometimes
femoral
called your
head
lateral
fits
collateral
into
ligament,
it, especially
tibial
in pediatrics
or
and
medial
developmental
collateral
hip
ligament,
dysplasia.
the oblique popliteal ligament, and the
Okay,
arcuate
femur.
popliteal ligament.
Longest and heaviest bone in your body. Proximal end consists of a head.
So your
neck,
patellar ligament is
greater and
actually
lesser
distal part of the
trochanter.
quadricep tendon. That
So in the
extends from
humerus,
apex
they're greater
of
and
the
lesser
patella to that
tubercles.
tibial
In
tuberosity
the
we already
femur,
talked
the
about.
greater and lesser trochanter.
Has connective tissue expansions that join
This
with
is the kind of
fibers
thing
the
that
vastus
trips you up on the
medialis and
practical, that
lateralis
you'll
to
put
form
that
the
there's a
patellar
greater
retinaculum. You'll
tubercle
see this on
on
the
the
femur.
cadaver's.
There's this
Instead of
broad
saying greater trochanter, and
white
unfortunately it would be wrong.
fascial sheath
So
that
try and keep
surrounds
those
the
terms
patella
straight.
and
On the head of the femur is a
supports the
depression
patellar
called the
tendon as well.
fovea, which serves as a ligament attachment.
Below
for
this
the
ligament is
at
the
head of
infrapatellar
femur.
fat pad, which helps provide
The
cushioning
place
to
where
the
the
knee
neck
joint when you're
of the
kneeling.
femur joins the
And
shaft.
this is the ligament that is struck to
anteriorly,
elicit the
there's
knee
an
jerk reflex. So
intratrochanteric line.
it's the patellar ligament
so just
that
as it
you
says, it's
tap with a hammer when you're
intratrochanteric, runs
checking
between the
patellar
greater and
reflex.
lesser trochanters.
So here's
The
just
intertrochanteric
here is your
crest
patellar ligament
joins the
going
greater
into
and
tibial
lesser trochanters
tuberosity,
posteriorly.
and here is the supporting
Okay,
structures.
So here's
from
your
VMO,
intertrochanteric
and vastus
line
lateralis
on the
coming around.
anterior.
Then you have your
You have
iliotibial tract that comes in and helps
crest
supports it laterally,
posteriorly.
as well as
Okay,
your
so the
bicep
line is
femoris
anterior,
tendon.
crest is posterior.
And on the medial side, you have your hamstrings
you have
coming
your
around, and they're
femoral
going
head,
to attach
you have
just
the
lateral
neck
to
that
the
goes between the
tibial
head and the shaft.
An area that
your
we
greater
call the
trochanter is this large thing. Your lesser trochanter is a smaller one on the sartorius muscles. Okay, then you have your shaft.
Often
you have a lateral
by
epicondyle,
Sargent,
a medial
SGG,
epicondyle,
semitendinous
and patellar surface in between. Posterior view, you still have your head, your neck, you have your intertrochanteric crest.
Okay, so this is a view with the knee
trochanter
inflection,
again,
so
so
these
the
are your femoral
trochanter,
condyles, medial and lateral.
shaft,
Okay, and what
the
they've
linea
done here in the knees
aspera,
inflection, and this is a nice
part
picture
of the
to show you the
attachment for the
menisci, medial
hamstrings, but
menisci,
again,
lateral menisci.
Such a
What
broad
they're really
sort
showing you
of
here is this is the articular
attachment that
surface
we're
of the
not gonna
patella.
focus on
This is
very
the
much.
underside of the patella that's going to articulate with this.
Okay, so again, your linea
trochlear
aspera is
groove
broad,
right
rough, lateral, and
here.
posterior
And this
surface,
is the fat
muscle
pad that
attachment
surrounds
site.
it. There's a lot of fat.
Again, not palpable.
Around your knee.
And
There's a super
again,
patellar
we'll barely
fat pad
see
and
it
there's an
on
infrapatellar fat pad.
cadaver
And they
unless
provide
we
cushioning and
take
some
all the
shock
musculature
absorption,
off,
especially when you're actually kneeling on the knee.
which we might do. So do we care about these?
Okay, your collateral ligaments.
No, we're not going
In
to
the
go
clinic,
into
you're going to hear them called medial and lateral collateral ligaments.
Again.
They are trying to change the name.
Okay, so your femur, the medial and lateral condyles make up
fibular
nearly the
ligament
entire
because that is
distal
more
end of the femur.
Anatomically correct.
Condyles are separated by
Where
an
they run from.
intercondylar fossa.
Your fibular collateral
Shallow
ligament is
anterior
very
depression
round
is
and
called the
cord-like.
patellar surface. In the lateral surface, the lateral condyle
Tendon
has
of
a
the biceps
central
femoris
projection
is
that's called
split
the
into
lateral
two parts by
epicondyle,
this ligament.
and there's a medial
Sometimes,
epicondyle on the medial
not always.
side, which is much larger.
Tibial collateral ligament is much more often injured.
On the medial epicondyle
It's
as
a
well,
much
you have the
broader,
adductor
wide,
tubercle,
fan-like
and this does serve as an
ligament
attachment
than the
site
lateral.
for the
Lateral
adductor
is very
muscles.
palpable because of that.
Okay, so if we look at the distal end, we have this lateral
medial sort of
epicondyle
blends in with
and
a
the
lot of
medial
other things on the medial
epicondyle.
side, so it's not
You'll
as
notice when we
prominent for
palpate these,
palpation.
and I'll tell you again when we palpate them, that it's very difficult, if sometimes impossible,
Okay, here is your
differentiate
medial or
the
tibial
medial
collateral
epicondyle
ligament
from the adductor
You're going to see it runs
tubercle.
quite a bit longer
They're
down
very
the
close
tibia
together,
than the
and some
lateral
people
does.
they just sort of
much
feel
broader
like
and fatter.
a single
It does
bump. In fact,
have
in
an
most people, they feel
attachment,
like
a
a single bump.
continuation.
Please note
into
too
the
that the
medial meniscus.
epicondyles are on top
Okay,
of the
the medial
condyles.
meniscus
They are
is going to
technically
have a
part of the
continuation into your
condyles.
ACL.
They're just the
So
most.
this is the injury that is
The
often called
epicondyles
the
are the
triad,
most prominent or
and it's the
pointy
injury
part
of the
of
medial
condyle,
collateral
and
ligament,
that's the best way
the
for
medial
you to think
meniscus,
about when,
and the
especially when you
ACL.
have to palpate them.
because they have they all attach to
Okay,
each
then
other.
on the anterior view,
The
in
lateral side, you
between
can see
the
this is
condyles,
much
you
more
have this
cord-like.
patellar
It's not
surface,
completely
and that's where
attached to
your
the bony
patella
structures
is
like
going
the
to
medial
articulate
is,
with
and that
the
also
fe-
makes
the
it a bit
femur.
more palpable.
And posteriorly, you have an
Lateral
intercondylar fossa.
meniscus, not a
Okay,
direct
so posteriorly it's
contact
intercondylar
of the lateral
fossa,
collateral ligament to the lateral
anteriorly it's
meniscus.
intercondylar patellar surface.
First of all, lateral side of your knee is much often less
The
injured.
hip joint
than
itself
the medial
is
side.
a ball and socket type of joint. It's
So
around
both
the
the
head of
MCL and
femur
LCL,
with that
medial
acetabulum.
and lateral or tibial
The
and
acetabulum,
fibular
just like in the
collateral
shoulder, we
ligament,
talked about
stabilize
the
the knee joint
labrum.
on each side.
There's an
Tight
acetabulum
during
ligament as well
extension,
that helps
which
deepen
helps
the socket
prevent
and
rotation
increase
of
the
the
stability of
femur.
the hip joint.
Inflection,
You have
however,
flexion,
quite slack, and
extension,
therefore not effective in
abduction,
preventing rotation.
adduction, rotation.
So the MCL can
something
be
we
torn
call
by a lateral
circumduction
blow to
that
the
can
knee,
occur
while the
at the
LCL is
hip
most
joint.
often torn by a medial blow to the knee. So if you picture,
Okay, so here's your
just
hip
occurred.
joint.
If you
Here's your
picture in
acetabular
football,
labrum.
Many injuries that you
Right?
see
It is
are occurring when a
cartilaginous.
runner is being hit
It
from the
deepens your
outside
acetabular
of the
socket.
knee towards the
and it
inside.
articulates with the head of the
Okay.
femur.
It's a lot harder to get hit from the inside. So that's why when you're running, you're typically hit from the outside, and that's
You have
where
a ton
why
of
you have
ligaments supporting
MCL,
your hip joint.
medial meniscus,
The
and
most
ACL
important I'd
injuries
have to
much
say
more
is the
than lateral.
iliofemoral ligament. Attaches to the anterior, inferior,
Okay, you have some
anterior
intra-articular
iliac
ligaments,
spine,
meaning
and
they're
remember the acetabulum.
inside the
They cross
joint.
over the hip joint to
Okay,
attach
these
the
are your cruciate ligaments and the
intertrochanteric
menisci.
line. It is
Your cruciate
Y-shaped.
ligaments, your
Sometimes it
ACL
is
and
called the
PCL,
Y
are
ligament.
located inside the joint
Fibers
capsule.
run inferior
So that makes
laterally.
them
As you go to
intracapsular.
stand, this ligament twists the femur
These
into
two
the
ligaments hold the
acetabulum.
femur and the tibia together, especially when in flexion.
And we may actually get
When
to see
viewed from the
this,
side, they cross each other in the shape of an X.
Working on
That's
some
why they're called
cadavers
cruciate.
this summer, and
They are
if you
named
get this
anterior and
particular type
posterior
of
according to their
involvement
attachment
that
on
we
the
had this
tibia.
summer, you'll actually get
Anterior
to
on the
see
anterior
this
side of the
twisting
tibia,
motion.
posterior on the
As
posterior
you move the
side
hip
of
from
the
flexion
tibia.
into extension, you'll see that
Anterior
ligament
cruciate is the
twist,
weaker of the two
and it
ligaments. Goes from the
kinda sucks
anterior
the femoral head
intercondylar
into
region
the
of the tibia,
acetabulum to make it a little
runs
bit more
superior, posteriorly, and laterally
stable.
to attach the posterior medial side of the lateral condyle.
You have a pubofemoral ligament attached to the upper part of the
It
superior
does have an
pubic ramus
attachment
and
to the
pubic
medial
bone.
meniscus, as I've already
Crosses
said.
the
It
hip
has a
joint and blends
relatively
into
poor
the
blood
iliofemoral
supply,
ligament.
therefore it does not
Fibrous
heal
capsule.
well when
So
it's
again,
injured.
this is another area
It
where
is
these
taught in
delineations
extension
of
and
origin and
flexion.
insertion really are not this
Its
clear
main job
cut.
is to help
Textbooks
prevent
like to chop them
posterior
out as
displacement of the
goes
femur
from here
on
to
the
here,
tibia,
but
and
generally these
anterior
things
displacement
run
of the
together.
tibia on the femur. It also has some role in
And then you have your
preventing hyperextension
ischiofemoral,
of the knee
located on the posterior surface of the articulation.
Okay,
Attaches
so
to
here you
the
go.
ischial
Here is your anterior
part of the
cruciate,
acetabular
and here's
rim.
your posterior cruciate. You see
and then is going to run out towards the neck of the femur and the greater trochanter.
Here's your knee in extension.
This one prevents excessive medial rotation
and you'll actually be able to
and also posterior dislocation of the head. if your femur is in
Posterior
hyperflexion. So if you had
is the
your
stronger of the
knee
two ligaments
up real high
from
towards
posterior
your
and
chest,
the region
your
tibia
hip
passes
flexed
superior
fully,
and
and there's
anterior
large
and medial
force that came out your
attached to the
front
anterior
or
lateral
knee.
surface of the medial condyle.
This ligament would
of the
prevent
femur.
a posterior
It is
dislocation
tight
of the
during
femoral
flexion of the knee. It helps prevent anterior displacement of the femur.
Okay, you also have your zona
posterior displacement
orbicularis.
tibia
Not
and the
really a
femur.
ligament, but it's a thickening of the joint capsule that just runs sort of circular
stabilizer of the femur.
Around the head of the femur and helps to stabilize
Here's
the
an
joint
actual
posteriorly.
cadaverous ACL.
Again, cadaverically,
ACL,
we're not going to be
medial
able to
or
differentiate
collateral,
this from the rest of the issue.
Lateral or fibular collateral.
Okay, your transverse acetabular ligament.
Okay,
this
your
one
knee
we should be able
also
to
has
see.
two menisci.
This
They're
one
both
actually
C-shaped
forms the
pieces of fibrocartilage
inferior
on top of the
surface of the acetabular. So you have your acetabular labrum that is running about 3/4 of the way around the
thick on the
acetabulum.
periphery,
But then you
thin
have this
out
transverse
as they move in
acetabular
towards the
ligament
center.
that connects
So
the
here they
medial
are.
and
This is
lateral
your
parts
medial.
of the
This is your
acetabular labrum.
lateral. Right, lateral is quite a bit more C-shaped.
What this ligament does, it
medial
helps
is quite a
prevent
bit bigger and
inferior
thicker here in this
dislocation
area.
of the femoral head.
And these are the tibial condyles.
And then you have the ligament of the head of the femur.
Coronary
This
ligaments
one
are
goes
capsular
right
fibers
from
that
the
attach the
acetabulum
margins
itself
of the
to
menisci
the head of the
tibial
femur. There's a
condyles.
fovea.
And then you have a transverse ligament of the knee that
this
joins the
ligament
anterior edges of the
runs
menisci
to.
tied together.
It doesn't really prevent movement
So here's
too
your
long.
transverse.
It's,
Right
if you're going to dislocate, this thing's going to rupture very quickly. But
Posterior
the important thing is that
femoral
it
ligament
carries
joins
the
femoral
artery
meniscus-
of the head
lateral
of the femur,
meniscus to the PCL,
which supplies the
medial
head of the
femoral
femur.
condyle.
So it's very important that when this is disrupted,
Okay,
you may
first
have
then
a
you'll
loss
go
of
through
blood
these quickly
supply
because
to
we're
the
not going
head
to
of
see
the
these
femur.
in the cadaver.
And the head of the femur could die.
We treat them a whole lot. They usually are other things that we're treating at the same time.
Okay, the
Patellar
other joint you have here is your sacroiliac joint.
Freely during knee
There are actually
flexion.
two of them. One on each side. It's a very strong weight-bearing joint,
tendon.
and it's the anterior joint between the auricular surface of the ilium and the auricular surface of the sacrum.
A lot of knee injury, and sometimes it's the
Okay.
bursa swelling.
A posterior joint between the sacral tuberosities on the
tendon of
sacrum
popliteus
and the
lateral
iliac
condyle tibia.
tuberosities on the
And
ilium.
serine, this one is kind of important. This is, remember I
We
said the
really
pes and
only
serines
talk
were
about the
sartorius
sacroiliac
subsidious
joint
and
as
tendinosis
being this
attaching the
articulation between
tibia,
the
so there's a
ilium
bursa
and the
underneath
sacrum.
this tendon to provide some padding.
When you
so
see it,
tendon
it
is
really
not
looks
broken
like
up.
one joint surface.
Gastrocnemius bursa.
Right, so
Six
here's your
proximal attachment
sacroiliac
tendon, the
joint.
medial head of the
They're
gastrocnemius.
describing it as posterior. This is an anterior
here's
view,
a picture of
and then a
bursa.
posterior
Yeah,
view,
not
but
too-
it clinically it is thought of as the sacroiliac joint, not
Okay,
two
musculature of the lower leg. They're divided into anterior deep,
joints. Lots of ligamentous support around here. You have anterior and
lateral
posterior
compartments.
sacroiliac ligaments
Anterior
to help
includes the
hold
tibialis
those bones
anterior,
together. There's an interosseous sacroiliac ligament and a sacrotuberous. The sacrotuberous
lateral
passes
includes
from the
fibularis
posterior
longus
ilium
and fibularis
down
brevis.
to the ischial tuberosity.
Posterior includes that
And this we
gastrocnemius,
will
soleus,
find on the
plantaris,
cadavers. It's actually a very
popliteus,
good landmark to
flexor
help
hallucis
you
longus,
find where you
flexor
are in the
digitorum
buttock
longus,
area.
and tibialis posterior.
Okay, so you have, this is
Okay,
your
your
anterior view
compartment
here, your
muscles
anterior
to the ankle
sacroiliac
joint
ligaments,
and cause
again, this
ankle
big,
flexion,
broad, complex
dorsiflexion.
blending
Bring your toes
of,
towards your
of
nose.
ligaments together.
Inferiorly anterior
Down
compartment,
here,
there are
this is
two
your
bands of thickened
sacrotuberous,
fascia
so it's
that
running
form
from the
superior
spine of the
inferior
sacrum
extensor retinaculum
to the
that may
ischial
help hold the
tuberosity
tendons
posterior.
down so that they don't bowstring.
And then you have a
during action.
sacrospinous running from the sacrum
Okay,
to
so
the
here
spine
is your
of the
tibialis
ilium.
anterior. It runs just to the lateral side of the tibial plateau or the tibial spine, and then crosses
This is now a
medially,
posterior view.
at the ankle.
So here's
to
just showing you the
attach
same
to
thing,
your
sacrospinous
first
and
cuneiform.
sacrotuberous. Sacrotuberous is running down to sacrum.
Extensor convert. This is
to
your
the
extensor
ischial
hallucis
tuberosity.
longus. Extensor
Sacrospinous
hallucis
is running
longus.
horizontally
Dorsiflex
across.
is your great toe.
And then you have your
first big toe.
posterior sacroiliac
Okay, and
ligaments all
you
up
can
here. Again,
differentiate
this
that
all
from
looks
the
like one
tibialis
very
anterior
broad,
tendon by
fascial
tracing
sheath
tibialis
on the cadavers.
anterior
You
tendon is
definitely
going
can
to
find
stop the ankle
sacrotuberous,
joint.
and sometimes we can differentiate.
Extensor hallucis longus is going to
sacrospinous,
travel
but,
farther to the
under
big toe.
sacrotuberous, so sometimes we lose it with sacrospinous.
Extensor digitorum longus. These are deep to
Okay, your
the
pubic
anterior
symphysis is the
tibialis.
third joint.
They
It's a
are going to
symphysial
separate
surface
into
of the
5
pubic bones,
different
articulating with a
tendons down here
fibrocartilaginous disc.
to go to
You have
each
very
of your
little
toes.
movement here.
So it becomes
Um,
tendinous superior
but
to the ankle
if
joint
you
from the
have
4 tendons that attach to phalanges of
Ilial
digits
and
2 through
ischial
5.
movement, you'll have pubic movement. Your ilia and ischia cannot move without movement occurring at the pubic
Again, it's
symphysis,
deep to tibialis
which is right
anterior.
here. So obviously this is an
Lateral
X-ray
compartment
that
muscles
helps
consists
in
of only
the
2
area,
muscles,
and here's your
fibularis
pubic
longus
symphysis.
and fibularis brevis.
These
are also known as peroneus
I
longus
think this
and
is
brevis,
obvious, but
or
the
peroneal
most movement you
longus
get
and brevis.
at this joint is during labor.
They
and
changed it from peroneal to
delivery, for
fibularis
your pelvis
about
to
3
open
or
and
4
allow
years
passage
ago.
of the
So
fetus.
older clinicians are still going to refer to these as peroneus longus.
Okay,
and brevis.
so let's talk
And
about
we
some
will need to know
musculature of the
both ways.
thigh. They are
Their
anterior
job
thigh
is to
muscles,
evert the foot, to turn
and they are
the
the
foot
hip
sideways
flexors
to
and
the
knee
outside.
extensors, mainly innervated by the femoral
Fibularis
nerve.
brevis is deep
The
to
medial
fibularis
thigh
longus.
muscles that are mainly adductors.
So
and
the important thing about
innervated by
fibularis
the
longus
obturator
is going
nerve.
to start by the
Your
fibular
posterior
head, it's
thigh
going to travel
muscles are
distally, it
the
wraps
hamstrings
behind your
innervated by
lateral
sciatica.
malleoli, goes to the base of your
So
fifth
a little
toe,
easier
and then
to
it crosses
know
on
the
the bottom
innervations
of your
here
foot,
because if it's
and it
anterior, it's
actually
femoral.
attaches to the
If
base
it's
of
medial,
your
it's
first
obturator.
metatarsal.
If it's
So
posterior,
it
it's
helps
sciatic.
actually to support the arch of your
It fits
foot,
a little
the
neater
transverse arch
here
of
in
your
the
foot.
thigh area.
So this is why it's longest, because it's going
Muscles
to
of your
travel quite a
anterior
bit
thigh are
farther
the
than the brevis.
iliopsoas, chief and
Brevis
most powerful
runs in the
flexor
same
of the
distance.
thigh.
A 2 is going to go behind your lateral malleoli,
When I mean,
but it's
you have
going
to
to
think in
stop
these terms when I
at the
say
base
flex
of
of
your
the thigh.
fifth metatarsal.
Clinically, what you're going to
It's
see
not
is
going
hip
to push
flexion.
under the foot. It's not going to go any further.
Most of its mass is located in the posterior wall of the abdomen.
If you remember, we pointed
Posterior
out
compartment.
iliopsoas in the previous
These are
lecture.
the
largest muscles of your lower leg.
We have two
They're
muscles,
divided
the psoas major
superficial
and minor,
deep
and the
groups.
iliacus.
Superficial group includes the
To
gastrocnemius
flex the
soleus
free
and
limbs,
plantaris.
such as in the swing
And
phase
your
of
deep
gait,
group
or when
includes
lifting your leg to
popliteus,
climb
flexor
stairs.
hallucis
But
longus, flexor
if you are
digitorum longus,
standing
and
and your
tibialis
feet are fixed on
posterior.
the floor, iliopsoas can also
Gastrocnemius, two
flex
heads,
the
both the
trunk.
medial and lateral
So it
head.
can pull your
Note
lumbar
that the
spine
medial
into
head
flexion.
travels farther than the lateral head. These muscles then
Anterior
form
thigh,
this
your
broad
quadriceps
fascial sheath
femoris.
here that
These are your
become your
quads.
Achilles
Okay,
tendon.
the main bulk of the anterior thigh.
Okay. The real name for it is
Four
calcaneal
parts:
tendon,
the
but
rectus
you'll
femoris,
hear it as
vastus lateralis,
Achilles.
vastus
It
medialis,
is a two-joint
and
muscle.
vastus
It crosses the
intermedius.
knee joint. So it
Each of the
crosses
four
both
individual
the knee and the
muscles has
ankle.
its own
So it is
origin,
a
but the
two-joint
tendons
muscle.
unite
It
to
has
form
minimal function at the knee,
single broad
but it can do some
aponeurosis
functioning.
and the quadricep tendon.
Soleus, deep to
So
gastrocnemius.
ligament is a continuation of the
Postural
quadricep
muscle.
tendon
When you're
that
standing
wraps
upright,
around
the center of
feet,
gravity
the
is slightly
patella,
anterior,
and it sort of
your
embeds the
your
patella in
soleus
the fascia,
continuously
and then
fires
attaches
to sort of
the
help
patella
maintain
to
your
the,
balance there.
tibia anteriorly at the patellar tuberosity.
Plantaris, I know. I keep teaching this muscle. I don't get it.
Okay,
it's a very,
so here are
very
the muscles
small
of your
muscle.
anterior
Has a
thigh.
super
You've got
long
vastus
tendon.
medialis.
So I'll tell you when
You've
you're
got the rectus femoris, vastus lateralis, and then intermedialis is going to be behind and underneath, deep to the rectus femoris.
Popliteus, thin triangular
here
muscle.
you have,
standing with the knee
this
locked
is
in
the
extension. Popliteus acts to rotate
tendon.
the femur
If
laterally.
you see all of
releasing
these,
the
so
knee
here's
from
tendon,
locked
vastus
position so
lateralis,
that you
here's
can move
rectus
into
femoris.
flexion again.
Medialis is sort of underneath. They
This-
all
the
form
function of
one big
popliteus has
broad
been questioned,
attachment
and
that sort of engulfs and wraps around
We're not
the
really
patella,
sure that
and then
it does do that
continues down to
unlocking
the tibial
mechanism, but
tuberosity and becomes the
we'll look at the
patellar
literature
ligament.
about that in kinase. Posterior compartment muscles. Flexor
Your other
hallucis
muscle here is your
longus, going to
sartorius.
go
This is
to
a
your
large,
great toe, and it
long,
flexes your
strap-like
great toe.
muscle.
So you
It
can
crosses
see
two
that it
joints.
is going to
So if you
travel
notice
all the way
here,
to your
it's
great
starting
toe
on
so
the
that it can
anterior
flex it.
superior iliac spine, and so that means
And then you
it's
have
crossing
flexor
the hip
digitorum
joint.
longus, which runs
And
right
it also
next to
then
it,
goes down
but
and
it's going to broaden
inserts
out into all these
into
tendons,
what we'll call the pes
similar to how
later, and that is on
extensor
tibia, so
digitorum
it is also crossing
separated
the
into
knee.
a tendon
So
to
it's
go
a
to each toe.
two-joint muscle. It has the ability to both
Tibialis
flex
posterior.
the
Tibialis
and to
posterior
extend the knee.
is an inverter, so it starts though on the lateral
It also
surface,
can
and then
weakly
it crosses
abduct and laterally
medially
rotate the
to
thigh
insert
at the
on the
hip,
medial
although I
side.
think it is
It's an
really,
inverter.
really sort of a weak muscle at that. We tend to call
So
the talar
these
muscle.
are the tendons
Sometimes
as they
it's called
come
the
around.
talar
This is on the
muscle
medial
because it
side
can
of the
flex,
foot. This is
externally rotate,
medial
abduct,
malleoli
so
right
when you're
here.
going to
These structures are all going
put
to
your ankle
pass
on the opposite knee,
posteriorly to them. We think of them
the
as Tom,
sartorius
Dick,
does all
and
of
Harry.
those motions.
Tom is tibialis anterior. Dick is flexor digitorum.
Tensor
and Harry
fasciato,
is
whether it belongs in the
hallucis
anterior or
longus.
lateral thigh, I'm not really sure.
Okay, so from
I
medial
tend to think
to
of it as more
lateral,
lateral, but
it's tibialis
it can be
anterior. Flexor digitorum.
the muscle inserts into iliotibial
hallucis.
tract. Everybody heard
Okay,
of
and then you
IT band
also
syndrome?
have
That's
the
this
posterior
muscle.
tibial nerve.
Primarily
and
acts to
artery
flex
are
the
also
thigh
going
at the
to
hip
run
because of its
along
anterior location. However, it generally doesn't act independently. It assists iliopsoas and rectus
Okay,
femoris.
an important area behind the knee
it
is
can also
popliteal fossa,
assist
the
the
diamond
abductors
shaped
and medial
space posterior
rotators.
to the knee.
And it
It's
also
a
helps
passageway
stabilize
for all the
femur
important
and
nerves and
so
blood
it does
vessels
lots of
on the
things,
way
but when you
from the
see it, it's
femur
really
to the
quite a
lower
small
leg.
muscle.
Borders are
So
the
it doesn't develop a
bicep
whole lot
femoris,
of force.
membranosus, and
Here's your tensor fasciolata.
gastrocnemius, medial
Okay,
and
the
lateral
tensor
heads.
fasciolata is going to continue
don't really care about the
distally and
root
turn
is-
into iliotibial
Its
tract.
contents is what we care about. The
Iliotibial tract is fascia.
termination
It
is
is
not
not
small
muscle. It's
saphenous
very
vein.
thick,
Popliteal
leathery-like
artery and
stuff.
vein. Tibial and
So
common
the
fibular
tensor
nerves,
fasciolata is just the
medial and
muscular
lateral
part, but
sural,
it does
cutaneous
continue
nerves,
and become
popliteal lymph lymph nodes and vessels. Okay, so here is the structure.
Medial thigh, your
And this
adductors,
is all the
pectineus,
nerves and
adductor
arteries
longus,
that are going to be
adductor
passing
brevis,
through there.
adductor
So
magnus,
it's sort of
gracilis,
like the
and
adductor
obturator
canal, but it's the
externus.
popliteal one because it's at the back of the knee.
General rules.
All right.
All of them originate from some part of the pelvis. All except gracilis insert into the femur. All except obturator externus are hip adductors, and all except pectineus are innervated by the obturator nerve. Pectineus has its own nerve, the nerve to pectineus. There's your little pectineus. Little tiny muscle. And then your adductors. Very difficult to see because they're deep to the quadriceps, but you'll see the gracilis is the long medial, again a medial strap-like muscle, and then your adductors are deep to that. Much easier to see on the cadaver. So here they are. Here's gracilis. Oh, no, this is adductor. Yep, that's gracilis. And then you have adductor magnus. You have pectineus underneath. Iliopsoas cut here. And the other adductors are deep to this. Adductor magnus. Again, these origins and insertions are here, but please go by the muscle charts. The magnus has both hamstring and adductor parts to it, so it is both a knee flexor and an adductor. Oh, and here is gracilis. Obturator externus, this little teeny tiny muscle here deep in the butt area. So here's obturator externus, and there's an obturator internus as well, but they're very small muscles, but we'll find them. Posterior thigh or hamstring group, semitendinosus, semimembranosus, and bicep femoris. Again, refer to your charts for origins and assertions. They have a proximal attachment of the ischial tuberosity. All cause extension of the thigh or the hip and flexion of the lower leg. All of them are innervated by sciatic nerve. A nice, neat muscle group. Okay, your bicep femoris has both a long head and a short head. Long head and a short head. You have semitendinosus comes medially. Bicep femoris goes lateral. Semitendinosus and membranosus are both medial attachments. That's how you can differentiate them. Tendinosus on top, membranosus is deep to semitendinosus, and both heads of the bicep femoris are going to go to the lateral surface of the knee. The gluteal region. 3 large gluteal muscles, which are hip extensors and abductors, and 5 smaller deep muscles, which mainly are lateral hip rotators. So your gluteus medius and minimus, fan-shaped muscles. They sit into that ilial fossa, share the same action and nerve supply. Look to your charts for those. So you've got, again, we have to talk about layers here, right? Gluteus maximus is the top layer. Deep to maximus is glute medius and the minimus. Okay? So you have to reflect glute maximus before you can see medius and minimus. Okay, here is minimus. And here is medius. Okay, again, you look, minimus is kind of under medius. So we're talking layers here. And then you have the little piriformis muscle that also runs in that area. So your piriformis is a pear-shaped muscle that sits in the posterior pelvis. The most significant thing we know about this piriformis muscle is that the sciatic nerve either passes under it or through it, depending on the individual's anatomy. So very important in treatment of sciatica. And here's just all of them deep. I'm going to try and pull up Anatomy TV and show you these later. Okay, other muscles of the gluteal region. Obturator internus, superior gemelli, inferior gemelli form a tricipital muscle called the triceps coxae. And they occupy the space between piriformis and quadratus femoris. Common insertion of these muscles is the medial surface of the greater trochanter. We tend to look at them as a unit because they cannot act independently, so when they act together. And here they are, deep in here. You have superior gemelli, nice tiny little guy, inferior gemelli, and this should be quadratus, I believe, quadratus femoris. Superior gemelli, obturator internus, and the inferior gemelli. Obturator internus is difficult to find on the cadavers, but we'll find it in superior and inferior gemelli we can find. Quadratus femoris, a flat muscle inferior to obturator internus and the gemelli muscle. Okay. Okay, so let's look at some of the hip musculature here. Here you have gracilis, adductor magnus, pectineus, and the obturator externus. Okay, so we're going from deep to superficial now. We're going to add on now here adductor brevis. Okay, we've added gracilis, iliopsoas, tendon, gluteus minimus. So let's turn this a bit. Okay, here's gluteus minimus. Here's piriformis. Okay, now on top of this, we're going to layer in. Here is now glute medius. Okay, and let's go on ahead right here and add in gluteus maximus. Okay, in reality, I have to honestly say, in reality, maximus is going to cover more of medius than this is showing. Let's go back a little bit. Okay, here's we're still on the posterior side now, so here's adductor magnus from the posterior side. Let's go back around to the front and start layering in some more. Okay, so adductor brevis we saw already, right? Okay, we're starting to add in our quads now. So here's vastus medialis. Let's rotate a little bit more. Okay, vastus medialis, vastus intermedialis. Now on top of that, we're going to add in rectus femoris. Okay, vastus lateralis, medialis, femoris on top. Now we've added in that tensor fascia lata and that big beautiful ITB band. Okay, so you've still got maximus, medius, iliotibial tract. And see how this all just joins in together? Okay, and we've got bicep femoris long head, vastus lateralis, semitendinosus, semimembranosus. Okay, really just one layer posteriorly is the hamstring muscles. Nicely, one layer. Okay, let's get back to our lecture. Okay, the lumbosacral plexus. So you have brachial plexus, obviously, right, in the arm. In the lower extremities, you have a lumbosacral plexus, formed by the lumbar and sacral nerve plexi, named the lumbosacral plexus because it is substantial overlap between the two. Many fibers from the lumbar plexus contribute to the sacral plexus. Formed by the anterior rami of the spinal nerves L1 through S4. Small contribution from T12. Serves mainly the lower limb, but also the abdomen, pelvis, and buttock, locating the walls of the pelvis posterior to iliopsoas. Okay, so here if you look on this side, iliopsoas is here, right here, psoas minor and psoas major. Here they've reflected it, and that's sort of where your plexus starts to sit. There are both anterior and posterior divisions. Yellow is posterior, green is anterior. This is, I don't know, I always think brachial is harder, but students usually tell me that the lumbosacral is harder. I think it's because of all this mess down here of all these anterior and posterior divisions and the terminal branches again. Your terminal branches from the anterior division are tibial and sciatic and common fibular, or the peroneal nerve from the posterior division. Those are your big ones. Okay. This is your lumbosacral plexus. This over here is going to tell you, I don't care about subcostal, I don't care about iliohypo, ilioinguinal, genital femoral you need to know, lateral femoral you need to know, obturator, femoral, superior and inferior gluteals, nerve to piriformis, common fibular, tibial. All right, basically you need to know the rest of these. I don't care too much about 16 and 17. Okay, but the rest of these you do need to know. I know there's no easy way to learn this other than to study it. Yeah, I got nothing to help you there. Sorry. Okay, so the other thing we care about in the femoral area is the femoral triangle. It's a fascial space that is bordered by muscles and ligaments in the superior third of the anterior thigh, and it's sort of a junction between the trunk and the lower limb. So it feels sort of like a depression in the anterior medial part of the thigh. It's inferior to the inguinal ligament when the thigh is flexed, abducted, and laterally rotated. The base is formed by the inguinal ligament. Medial border is formed by adductor longus. Lateral border by sartorius. The apex of the triangle is where the lateral border of the sartorius crosses the medial border of the adductor group. And the floor is iliopsoas and pectineus. So here's what it looks like. Okay, why we care? Femoral artery and nerve are passing through here. Okay, very important. This is how you get blood supplied to the lower extremity. Around the femoral artery and vein, there's a fascial tube called the femoral sheath. The sheath allows the femoral artery and vein to glide deep to the inguinal ligament during movements of the hip. So as you're flexing, standing, medial and laterally rotating your hip and thigh, that sheath allows the femoral artery and nerve not to get compressed and allows them to move sort of in their own little sac, or canal as they call it. Sorry, I don't know why this keeps doing this. Purpose of femoral canals: allow the femoral vein room to expand when venous return from the leg is increased, such as with exercise and activity. The adductor canal is another anatomical structure we care about. It is on the medial side, at the apex of the femoral triangle to the adductor hiatus in the tendon of the adductor magnus. Provides intermuscular passage through which the femoral vessels pass to reach the popliteal fossa, which is your knee. So the popliteal fossa is posterior at the knee. And that's where they change from becoming femoral vessels to popliteal vessels. Okay, femoral vessels supply your thigh. Popliteal vessels supply from your knee down. Okay, your femoral artery and vein pass through there, the saphenous nerve and nerve to vastus medialis. Okay, and here's your adductor canal right here. And another view of it. This is a cross-section if you chop through the thigh. Okay, so don't panic by the lumbosacral plexus. I have another little lecture that I'll post on lumbosacral plexus that simplifies things just a little bit, not a lot, because as I said, I can't really a whole lot simplify it. But so there'll be a separate short brief lecture on lumbosacral plexus.